Hello, this is from Dr. Mohammad Mahfouzul Anwar, Assistant Professor, Department of Medicine, Rangpur Medical College, Rangpur, Bangladesh. I'm going to present my research article, Sensitivity, Specificity, Predictive Values, and Accuracy of Clinical Diagnosis of Acute Stroke. This article is published in the Journal of Rangpur Medical College, March 2023. We all know stroke is a focal neurological disorder of vascular origin and sudden onset, and it is one of the leading cause of death and disability worldwide, particularly in the low and middle income countries, and the burden is increasing. According to Global Burden of Disease Study 2017, in 195 countries, the stroke incidence was 11.9 million, prevalence 104.2 million, stroke-related mortality 6.2 million, and stroke-related disability adjusted life years is 132.1 million. Of them, 80% of all strokes and 87% of stroke-related mortality, 89% of all stroke-related disability adjusted life years occurred in low and middle income countries. According to Heart Disease and Stroke Statistics 2022 updates, a report from the American Heart Association in the United States, more than 795,000 people had a stroke every year. Among them, 610,000 are of first and new stroke. In every 40 seconds, one patient developed a stroke, and in every 3.5 minutes, one patient died due to stroke. According to CDC, during the year 2020, 1 in 6 deaths from cardiovascular disease was from stroke. In Bangladesh, according to the Global Burden Disease Study 2016, number of the stroke was more than 161,000, and death due to stroke is more than 126,000. To prevent complications and permanent defects in stroke, early diagnosis is the key that can easily be obtained by a CT scan of brain. Although CT scan of brain remains the gold standard of treatment and differential diagnosis for stroke, it is not available everywhere in the world, and all the patient cannot afford CT scan of brain due to financial constraint or availability. Though it is available in the Western or developed countries, it is not available everywhere in the low and middle income countries. So previously, many studies described various clinical features and respective differentiation between the two stroke types. We know that stroke is two types: ischemic stroke, which is due to the occlusion of the cerebral vessels, and hemorrhagic strokes, which is due to the rupture of the cerebral vessels. And most strokes are ischemic strokes, near about 80%. And some of the authors presented formulas based on clinical evaluations, like the Shirira's stroke score. We know it is developed in 1991 in Thailand, and many validation studies are conducted on this Shirira's stroke score by different authors, and other different authors uses new classification tools. Also, there are Rossier scale conducted by the Nor et al. All those authors or researchers conduct these studies to distinguish the stroke subtypes clinically, in order to aid the clinician to decide about starting antiplatelet therapy in settings where rapid access of CT scan is lacking. And their results differ from one another. Like Anderson's et al. Found diabetes, atrial fibrillation, previous myocardial infarction, previous stroke, intermittent claudication are the favoring factor for developing ischemic stroke as opposed to hemorrhagic one. On the other hand, high alcohol intake, smoking favors hemorrhagic stroke. They found age, sex, and hypertension favored neither type of stroke. Anwar et al. Observed diabetes, atrial fibrillation, history of previous stroke, increasing age favored ischemic stroke. On the other hand, hypertension, family history of hypertension favored hemorrhagic stroke as opposed to ischemic stroke. Another population-based study revealed increasing age, previous stroke, and diabetes favored ischemic stroke, whereas ischemic heart disease, atrial fibrillation, hypertension, alcohol intake, smoking did not favor either type of stroke. In a hospital-based Copenhagen stroke study revealed diabetes and ischemic heart disease favored ischemic stroke, whereas age, hypertension, alcohol consumption, atrial fibrillation, and smoking were not predictors of stroke type. Another hospital-based stroke registry on 39,1 people showed smoking, hypercholesteremia, migraine, previous transient ischemic attack, atrial fibrillation, heart disease favored ischemic stroke, whereas hypertension was the only significant factor related to hemorrhagic stroke. Very interestingly, two large randomized trials, the Chinese acute stroke trial and the international stroke trial with 20,000 patients in each trial, have shown that starting daily aspirin promptly in patients with suspected acute ischemic stroke reduce the immediate risk of further stroke and death in hospital and the overall risk of death and dependency. The Chinese acute stroke trial, they conducted this study. The early use of aspirin within 48 hours without the prior of CT scan revealed that aspirin allocated patient develop less than 40% mortality and fewer recurrent ischemic stroke than the patient who did not get the aspirin as early as possible. Of them, 2% patient develop hemorrhagic stroke on the CT scan with no evidence of detrimental effect of aspirin. The odd ratio was only 0.86. On the other hand, recurrent ischemic stroke was relatively high on those who did not get the aspirin. The international stroke trial also demonstrated aspirin allocated patient without a prior CT scan, there is significant fewer recurrent ischemic stroke and no significant excess of hemorrhagic stroke. And further, they also revealed significant reduction in the death in aspirin allocated patient. A follow-up study of 2-year European stroke trial, use of aspirin to all patients omitting CT scan, showed 2-year excess risk of fatal and non-fatal hemorrhage 0.6%. And on the other hand, recurrent ischemic stroke not giving aspirin was 4.1%. So the objective of our study was to see the sensitivity, specificity, positive predictive value, negative predictive value, and accuracy of clinical diagnosis in detection of stroke subtype. The study was a cross-sectional comparative study conducted in the Department of Rangpur Medical College Medicine Department during the year of January 2010 to December 2011 on 300 suspected acute stroke patients. Purposefully collected the samples and ethical clearance is taken from the ethical committee of Rangpur Medical College. We exclude the patient who had no definitive CT scan change or having transient ischemic attack or stroke associated with hemorrhagical condition like leukemia and polycythemia. The clinical diagnosis of stroke type was made on the basis of mode of presentation, risk factors, clinical features, then confirmed by CT scan of brain within 1 week of the attack. Later on, the clinical diagnosis was compared with the result of CT scan analyzed by SPSS 19 for Windows. Age and sex of the patient, type of stroke, risk factors, clinical and laboratory variables were recorded. The most important risk factors of emphasis were hypertension, diabetes mellitus, ischemic heart disease, valvular heart disease, atrial fibrillation, peripheral vascular disease, smoking, alcohol, obesity, age more than 80, previous stroke, family history of stroke, hypertension, diabetes mellitus, and coronary artery disease. After extensive review of previous articles, we formulated our clinical basis of diagnosis of hemorrhagic stroke and ischemic stroke. The patient who suddenly developed coma, rapid deterioration of neurological state, headache, vomiting, convulsion, and hypertension were clinically diagnosed as hemorrhagic stroke. On the other hand, sudden onset of lateralizing sign, gradual deterioration of consciousness, deficit after awakening, diabetes, atrial fibrillation, rheumatic heart disease, ischemic heart disease, and previous stroke history of previous stroke were clinically diagnosed as ischemic stroke. Among the clinically suspected 300 patients, ischemic stroke was 227 and clinically diagnosed hemorrhagic stroke were 73. So the ischemic stroke was 75.7%. Male sex was prevalent in both stroke type, but there is no statistical significant difference. The mean age of ischemic stroke group is slightly higher in the infarctive stroke group than the hemorrhagic one, but there is no statistical significance. Regarding the clinical presentation, acute onset of focal neurological deficit, headache, vomiting, convulsion, coma, and raised systolic and diastolic blood pressure was significantly high in the hemorrhagic group. On the other hand, gradual onset of deficit, altered level of consciousness, deficit after awakening, and dysarthria were significantly prevalent in the ischemic group. Regarding risk factors, age more than 80, diabetes, ischemic heart disease, atrial fibrillation, and previous stroke were significantly high in ischemic group. On the other hand, hypertension and family history of hypertension were significantly high in the hemorrhagic group. So after CT scan, among the 73 clinically diagnosed hemorrhagic stroke, CT scan revealed 61 hemorrhage, 5 infarctive, 6 patients subacute hemorrhage, and 1 patient space occupying lesion. And among the 227 clinically suspected infarctive stroke patients, CT scan revealed 203 patients of infarctive stroke, 6 hemorrhagic strokes, and 18 space occupying lesion. We then analyze the performance of our clinical diagnosis against the gold standard CT scan on diagnosis of this stroke type. The sensitivity, specificity, positive predictive value, negative predictive value, and accuracy of clinical diagnosis over the CT scan for hemorrhagic ischemic stroke was 91, 94.8, 83.6, 97.4, and 94%. Similarly, the sensitivity, specificity, positive predictive value, negative predictive value, and accuracy of the clinical diagnosis of hemorrhagic stroke of our CT scan were 97.6, 73.9, 89.4, 93.2, and 90.3%. A previous study conducted by Islam et al. Also found the similar picture like us. Among 200 patients, they clinically diagnosed 67 patients as hemorrhagic stroke, and CT scan reveals 56 intercerebral hemorrhages and 5 infarctive strokes. Of them, 133 clinically diagnosed ischemic stroke, CT scan revealed 119 infarctive stroke, 6 intercerebral hemorrhages, and 8 space occupying lesion. We then compare our findings with the findings that the study conducted by the Islam et al. And the sensitivity, specificity, positive predictive value, negative predictive value, and accuracy were more or less similar between these two studies for hemorrhagic and ischemic stroke. We then analyze the overall performance of our study and compare our findings with the results that conducted by different authors using different scoring score or different their formulas or different new classification tools. Or the range of their result is more or less within the range of our study. But one article we found that Khan et al. Differs to our study. They have clinically suspected 43 ischemic infarction, 25 intercerebral bleedings, and 32 indeterminate. Of them, CT scan reveals 60% cerebral infarction, 27% intercerebral bleed, 9% space occupying lesion, and 4 hemorrhagic infarct. Finally, we compare the overall accuracy of our study with the study conducted by Hang et al. Using the Siriraj stroke score, or Kochar and Shah et al. Also the validated study on Siriraj stroke score, and a new scoring system conducted by Nor et al., that is Rosier scale, recognition of stroke in emergency department. And the results of the previous study is more or less similar to that of our study. So in conclusion, the diagnosis of stroke can be done clinically with high accuracy, but a CT scan of brain remains the gold standard for differential diagnosis. Adequate knowledge on risk factors and clinical features may distinguish cerebral infarction for intracerebral hemorrhage in order to aid clinician to decide the initiation of aspirin in the setting where rapid access to CT scan of brain is lacking. We had some limitations. We conducted the study in a single center on a small sample size, and we did not include the treatment in our analysis. So thank you.
So for the attendees,
I am Associate Professor of Internal Disease Department in Perm State Medical University, it is Russia. And I am a more than 20 years old experienced doctor, cardiologist, internal disease, and ultrasound diagnostic. And I am a passionate person in research, and it is some element of my personal research work, which I continue now time, and I'm very interested in a topic of features of chronic heart failure in patients with HIV infection. Because as you know, HIV infection, it is a great epidemic in all the world now. Now time, little decrease amount of cases of HIV in the world, but of course it is all necessary take under control. Am I audible? Audible well?
yes, ma'am, you're audible, ma'am.
Thank you very much. Arterial hypotension is a decrease of blood pressure more than 20% of normal values and equivalent to a decrease in systolic BP less than 90 millimeters Kg and diastolic BP less than 60 milliliters Kg. And possible that not enough of attention modern doctors take to the trouble of arterial hypotension. A lot of information about different variants of arterial hypertension, but arterial hypertension needing attention too. It's known that arterial hypotension is accompanied by hypoxia of organs and tissues. It's likely that the increased concentration of nitric oxide and lactic acid levels in the blood of arterial hypertension from special structural and functional changes of heart and vessels manifested by decreased adaptation to stress load. And it's also known that chronic heart failure may be the cause of arterial hypertension development, but just a moment not known exactly. Is arterial hypertension may be the cause of chronic heart failure? This question is opening, and the aim of my study was to study the features of arterial hypertension in patients with chronic heart failure infected with HIV infection in comparison with patients with normal blood pressure. The structure of this part of my research contains of 3 levels. In the first level, I observed 240 patients with HIV infection who got a treatment in a multifunctional, very large city hospital in different departments, and both of them was related with the diagnosis HIV infection. Between them, I have found a group of 160 patients with symptoms and signs of chronic heart failure. Chronic heart failure diagnosis are estimated regarding the European Cardiological Society guidelines with 2 points: clinical, echocardiographic, and NT-proBNP in a blood. In a third level, I found another group inside the group of second level, another group with arterial hypotension. It includes 44 patients. It is a great amount from 242 patients with arterial hypotension regarding the criteria. And totally, design of research presents that 44 patients with arterial hypotension, chronic heart failure and HIV, against 76 patients with normal BP level, without arterial hypertension, without arterial hypotension, only normal BP level, and inside this they have a chronic heart failure and HIV infection. My patient was complexly observed in a hospital. There was blood analysis, CBC, urinalysis, biochemistry, X-ray, ECG, and all another usual options. And additionally, from myself, they was observed in NT-proBNP, caspase-6 level in a serum of the blood, lipocaine level in a serum of the blood, cystatin C level in a serum of the blood. Myself, I done echocardiography for everybody of this cohort, and myself, I made non-invasive arteriography by Hungary equipment tensiomet. It is very easy, very comfortable device for clinical research because it working from one side as a daily monitoring of BP, but from another side, it give a lot of indexes of aorta and brachial artery stiffness, which give for us possibility to investigate the changes of the vessels, the stiffness of the vessels, of large vessels, diameter large. And regarding the results, patients with chronic heart failure infected with HIV are susceptible to developing arterial hypertension in 18.3% of cases, and it is a great amount. And in this cohort of my patient, I found that kind of features, that most of my patients with arterial hypertension was a male and less female. Most of my patients took alcohol regularly and had alcohol consumption. And p-value, you can see that here very high level of reliability. And body mass index in my patient was less, more in patient with arterial hypertension than in patient with normal BP level. Anemia was found in my patient more often with a higher percent of reliability than a patient with a normal BP. And the main index that unsuppressed virus load was more higher than in patient with normal BP. That is why we can say about impact of male gender possible alcohol, body mass index, anemia, and unsuppressed virus load. That this index is a negative impact on the duration of disease in patients with chronic heart failure and HIV infection. Then, after during echocardiography of my patient, I found that kind of features that diastolic dysfunction was found in more large amount of percent than in other index. It is left ventricle hypertrophy, which I was estimated regarding the rise of myocardial muscle index. But you will ask why arterial hypertension and rise of left ventricle hypertrophy. We will say that you need different. Left ventricle hypertrophy in arterial hypertension is different from left ventricle hypertrophy in arterial hypotension, because in arterial hypertension, prevalence the features of inflammation, of edema. That is why mass of myocardial will rise, but it is not classical. It is not a real hypertrophy. That is why edema of muscles, edema of cells appears. That is why this index rise, myocardial mass index. Next slide, I demonstrate for you here changes in the level of systolic and diastolic office BP. And in comparison with them, pulse BP in my patient, and more interesting, it is a pulse pressure in aorta regarding the data of tensiometer angiography, and pulse wave in aorta. And as you can see, I give you information only about aortic stiffness index, because in brachial stiffness index, there was no any difference in these two groups. I will remind that both groups had chronic heart failure, Both groups had HIV infection and different only in the level of BP. Else, what kind of difference I got? Triglyceride level was more higher in a group with a low BP, with arterial hypotension. Activity of aspartate aminotransferase was more higher in a group of arterial hypertension. And very interesting that cystatin level was less and glomerular filtration was higher in group with arterial hypotension in comparison with a normal BP level group. Also, very interesting features that lipocaine level was rise and caspase-6 level was rise a lot in group of arterial hypotension. And of course, this especially caspase-6 level, a lot of time I spent to explain what happened, why caspase-6 level rise in this group. This picture demonstrates for you changes in glomerular filtration rate, which I calculated by CKD-API formula with inclusion of cystatin C. It depends from arterial hypertension. Yellow column it is arterial hypertension, gray column it is a normal BP, and you can see that glomerular filtration rate, due to my research data, was more higher in a group of arterial hypertension patients. From another side, now you can see caspase-6 levels, independence of presence of arterial hypertension, and we can see that green column, it is arterial hypertension persons more high level of caspase-6 level. And it is take in attention, and it takes some additional explanation. On this picture, I demonstrate for you three rock curves. Rock curve gives some reliability results, not in all indexes. What inside my research, in three these indexes was reliability in rock curves analysis. Rock curves analysis, it is a prognosis analysis, not only clinical statement for today, it is prognostic analysis. And we can see, looking attention to the caspase-6, it is a blue curve caspase-6. We can see scleral curve, we can see p-value, we can see confidence interval, and later I will say what kind of different its meaning. Then look also to curves which demonstrate significantly reliability in my research. It is, of course, glomerular filtration rate and cystatin C rate level, but less significantly than caspase-6. If you can see the p-value, more higher p-value in caspase-6 level. Then we look another picture. What kind of conclusion am I able to do regarding this research? Caspase-6 cut off in rock analysis point is 184.35 picograms per milliliter. That means that caspase-6 more equal than 148.35 showed a higher risk of arterial hypertension detection in patients with chronic heart failure and HIV infection. Arterial hypertension may occur as a marker of active cardiomyocyte apoptosis in patients with proven chronic heart failure infected with HIV, when the level of caspase-6 in serum reaches 148.35 picograms per milliliter or higher. It is possible that the kidney is also involved in apoptosis process at the same time, because we can see that the same direction of changes present in the level of cystatin C, possible relative, but with caspase-6 exactly present changes. Caspase-6 is a key of apoptosis, a key enzyme of apoptosis. Progression of many cardiac muscle diseases is accompanied by intensification of cardiomyocyte apoptosis. Active oxygen species can trigger cardiomyocyte apoptosis by activation pro-apoptotic proteins, and caspases are in mitochondria-dependent manner present. Caspase-6, it is a very comfortable instrument for measurement apoptosis intensivity. And also, regarding my research findings, Correlation analysis was done between caspase-6 concentration in blood serum and GFR determined by the level of cystatin C, and was carried out. A reliable positive correlation of high closeness of CHEDEC scale was obtained. You can see R level 0.0702, and it is very close. The obtained pattern may indicate a possible simultaneous activation of apoptotic process on the background of arterial hypotension, both in cardiac muscle cells and kidneys in patients with chronic heart failure and HIV infection. It should be taken into account that apoptosis is a physiological mechanism of programmed cell death. It is possible that this is the role of apoptosis preserving the tubular function. Arterial hypertension in HIV-infected individuals is a consequence of severe autonomic nervous system dysfunction. It is known due to the literature. HIV is present in high concentrations in the hippocampus, basal ganglia, and other areas involved in hypothalamic regulation, and many inflamed cells have been found in this localization. That means the regulation of nerves, the part of central nervous system structures very higher in regulation of arterial hypertension. Here we can see about involvement of HIV virus inside the cells of central nervous system, of course, and its impact for appearance of system changes, including the intensity of apoptosis, and case of arterial hypertension appear due to this relative process. And conclusion, dear colleagues, patients with chronic heart failure infected with HIV are susceptible to the development of arterial hypertension in 18.3% of cases. A significant predominance of left ventricle hypertrophy and diastolic dysfunction was noted in the group of patients with arterial hypertension. Concentration of caspase-6 in serum equal to 148.35 picograms per milliliter and higher is a risk factor for the development of arterial hypertension and chronic heart failure in HIV-infected patients, indicating the intensification of apoptotic process in cardiomyocytes. GFR equal to 47.5 milliliters per minute, 1.73 meters square and higher, calculated by the CKD-API formula with inclusion of serum cystatin C level, is associated with a higher probability of arterial hypertension development. The obtained pattern may indicate both activation of apoptosis process against the background of arterial hypertension in cardiac muscle cells and kidneys, and preservation of glomerular filtration rate. Dear colleagues, thank you for your attention. Thanks for organizers of the conference for the invitation to participate with my report. Here you can see a very special place in our Perm region. It is a government reserve territory. It is a wetland mount, a very beautiful place. Invite you to Perm region. I was very glad to have possibility present my report, present a little part of my research. Thank you very much for everyone. If you have questions, please send in chat or orally. Thank you.
About CTO procedures, current perspective on CTOs and preparation principles and techniques. Now, in the field, the CTO procedures is so complex procedures, and generally with the technological improvements, we need more experiences about it, and we will speak about this topic and a case. I will try to speak about the CTO procedures in case based with a case of mine. In the chronic, to say a chronic total occlusion to an occlusion, it should be characterized by the complete blockage of the coronary artery for 3 months or longer. They are prevalent in 15 to 30% of patients undergoing coronary angiography generally. And these are, just as I said before, more complex procedures. Generally, patient and staffs taking more radiation, the patients generally taking more contrast, and it generally has more complications. Initial assessment is so important in that kind of patients. You need to have detailed patient history and physical examination. You need to make a good physical examination. After that, you need to use the imaging techniques such as coronary angiography and CT angiography to evaluate the length of occlusion, the existence of the calcification, and the calculation of the GCTO score. Because according to this kind of specialties of the lesion, you will change your strategy. You need to evaluate the risk factors, something like you need to identify them, comorbid conditions like diabetes, hypertension, or previous cardiac history. Previous PCI can direct you to instant restenosis or coronary surgeries, generally more complex patients for the CTO candidates. So you need to know all about those. Assessing the lesion characteristics and complexity is so essential in CTO procedures. Something like you need to calculate coronary calcium scores, because if you face to face a calcific lesion, in that time you need to use a rotablator or something like that. And just as I said before, you need to calculate GCTO score. In that time, you need to decide. You can decide that it's a hard case or it's an easy case, or it's a moderate case. You can calculate this, and you can know this with GCTO score. And pre-procedure planning is so important, because if you plan your strategy and if you plan your patient is good, in that time everything will be fine in the procedure, and your patients is going to be fine after the procedure. So formulating a procedure strategy, you need to formulate a procedure strategy. Then discussion with a multidisciplinary team, including cardiologists, anesthesiologists, and radiologists, working on videos of coronary angiography, scenes of the coronary angiography. You need to look the lesion length, the shape of the cap. It's the cap, blunt cap or tapered cap. Also calcification, lesion-related bifurcations, collaterals. Are they epicardial or septal? Microchannels, you need to identify the microchannels. Coronary anomalies, catheter, wire, and microcatheter selection is so important in this kind of complex procedures. So interprocedural planning is also one of the steps of the CTO procedures. So after your coronary angiography and after your first planning, then you will take your patients to the procedure. For this, your cath lab need to have some requirements, something like an experienced operator about CTO procedures. Then experienced nurse and technician really decrease the complications. Also, you need to have an ACT device to calculate the ACT during the procedure. Full of vital monitorization is important, because first, generally in a complication, first you can understand from the blood pressure or from the pulse. So you need to have a full monitorization, full vital monitorization. Specialized equipments are important, something like wires, microcatheters, dual lumen microcatheters, IUs, and or OCT can help during the procedures to the operators. And graft stance should be in the cath lab, because if you have a perforation of coronary arteries, in that times you need to use a graft stent. You can occlude it with a balloon. After that, you need to implant a graft stent. So you need to have sizes, and you need to have the something like all size of the graft stents. Also, you need to have a percutaneous kit, because sometimes pericardial effusions can occur in that kind of procedures, and you need to make a pericardiocentesis because of the tamponade. Also, intubation preparation for a bad situation you need to have in your cath lab. Okay, what about the procedure? You need to give a dual access. It should be biradial access, bifemoral access, or femoradial access you can use. So dual angiogram is something like the first step of this procedures. If you cannot do the dual angiogram, you shouldn't do this procedure, because you need to characterize the lesion characteristics, and dual angiogram is essential for this. First step, and out of the question to neglect, dual angiogram should be in these procedures. And the approach plan on the dual angiogram, you need to make an approach plan. And 80 to 100 unit kilogram and fractional heparin should be administered over 1 hour ACT check-in, and you need to make ACT 300 to between 300 and 350. Evaluation of the lesion, something like lesion characteristics, lesion length, classification, and count and length. You can see here in the picture, you can see occluded lesion, something like a 30 to 35 millimeter. It's a tapered cap, you can see. And after that, the distal of the RCA is filling from the left system. So this is not an easy lesion. And also you need to check about the microchannels. You can see upward picture. The proximal cap, something like a thick, could be thick, hard, or convex. Also, there should be some calcium, the proximal cap. But the core of the occlusion generally more soft, and there should be some microchannels. Then you can reach the distal part of the vessel. Also, distal cap, generally it's thin and concave shape. Now, this is a case of us, and this is the dual angiogram of the patient. You can see this the part of the RCA filling from the left system again, and it has good epicardial collaterals. And you can see after the right ventricular branch, the RCA is occluded, and it's about 45 to 50 millimeter occlusion. Then it goes with a microchannel, then epifurcation is PL and PDA, you can see here, and it's a complex procedure again. Now you can see the dual angiogram. This is the dual angiogram. Okay, the procedure. While you are in a procedure, penetrating, you need to be familiar with the wire advancing techniques. You need to go after you cannulate the left main and through RCA. You need to put a stiff wire to the donor artery to stabilize your catheter. Like we put here, you can see here in the LAD, we have a stiff wire to stabilize our left main catheter, the elbow catheter, because you can make an injury to the left main. You can protect the left main with this hardware, and you can stabilize your catheter. Then you will go to the occluded artery, RCA, with a soft workhorse wire with a microcatheter. Then you will go to the distal cap, proximal cap. Then you will start to exchange your wires. And while you are escalating your wires, you can use three techniques. One of them is penetrating, the other one is drilling, and the other one is sliding. If you have a microchannel, and if you have a polymer jacket wire, you can use the sliding technique. But if you have a calcified proximal cap, and there's no microchannel, in that time you need to use drilling or penetrating, and you need to have some stiff wires for this. And you shouldn't forget that you need to have a visible target and true lumen checking from opposite. Something like this case, you need to have a distal vessel place, visible place, and you need to check up. I will show it later. The opposite, you are in the right place or not. Now, integrated, there are three approaches for this. Integrated approach, you need to use this one in every case, and you need to choose in the first time integrated approach. Utilizing a forward direction approach to cross the occlusion. Techniques include the wire escalation and balloon angioplasty. And retrograde approach is assessing the occlusion via collateral channels from the opposite direction, often used after the antegrade approach, and after the antegrade approach fails. Hybrid approach, a combination of the antegrade and the retrograde techniques, provides flexibility and increases the success of the rate of the procedure. Okay, now this same patient, and we also tried firstly antegrade approach, but in these kind of patients, the length of the occlusion is so much. In that time, you can use primarily the retrograde approach as well. Now we go through the antegrade way, and you can see here there's a microcatheter, and this is our stiff wire, probably Gaia 2 wire, but it's subintimally progress here, you can see. And the next one, we are checking from the opposite part, and we can see that it's not in the lumen and it's subintimal wire. Okay, now we change our approach to the retrograde approach, and we go from the epicardials to the RCA. You can see here the progress of our wire. It's a cyan black wire. It's a soft polymer jacket wire, and you can see a caravel microcatheter behind of it. And we went through the RCA in that time. And here you can see in the distal cap, because we found a microchannel from retrograde part. So this, you can see here a microcatheter in the distal cap of the lesion. So now you can see that it's something like a 20 millimeter CTO lesion. After the occlusion, these are the microchannels. The other part of the vessel is microchannels. So this approach make our job easier. Now we put we advanced wire from antegradely, and because we need to know where we are going. So in the next part, we penetrating the distal cap with Concast Pro 12. Then with a soft wire, we make a tip into the guiding catheter, and you can see inside of the guiding catheter there is a microcatheter of us. Then we change the system to antegradely. You can see here, we changed the system antigradly with RG3 wire. Then, after angioplasty of the RCA, you can see a good inflow to the RCA, but there's a bifurcation here, so we need to wire both PL and the PDA, both of them. So we wired both vessel. Then we try to make an angioplasty here. But after our angioplasties, there is no flow in the PL, so we thought that this dissection, flap or hematoma of the posterolateral artery. Then we cannot be sure that in that time we couldn't be sure that, so we made a tip injection to be sure we are in the right place. You can see here we are in the PL with microcatheter. We are making a tip injection. Then we're making a angioplasty again, and now there is no flow in the PDA, and it also support our IDI. This is something like a flap, and sometimes it's closed to PL, sometimes it's closed to PDA. Then after we make sure that it's okay, there's a flap, we just make a kissing balloon angioplasty. Then we made a decay crash for this vessel, and you can see here this is a decay crash, second kissing balloon angioplasty, and after the final hot. This is our result. Sorry. This is our result of the vessel. Now, the common challenges in the procedure. First, you need to try integrate approach. Then there is some difficulty. If there's some difficulty in crossing the occlusion with guide wires, you need to have good backup catheter, something like AL catheter, and you need to use wire escalation. You need to go for harder and stiffer wire, something like Guide 2, Guide 3, or Conquest Pro wires. In the next step, parallel wire technique you need to use, or dual lumen microcatheters and IVUS you can use in that times. If you're in intimal place, you can understand that, or with IVUS where you need to go, and you can use after these techniques failed, you can use the retrograde approach. So microchannel tracking wires are so important hydrophilic polymer jacket soft wires. So sometimes the filter XT, Sion, or Sion black wires could be helpful for you. High quality taper type microcatheters is also so important for to go in the collaterals. High risk of procedure failure and complications you can face to face, so you need to be ready for these complications. But the potential complications of the procedure is perforation of the coronary artery, hematoma formation, and pseudoaneurysms. Management strategies include bailout techniques and utilization of covered stents. Also, the procedure, simple antegrade, and in the procedure you need to know simple antegrade and retrograde techniques. In the antegrade technique, single wire technique, multi-wire technique, something like parallel wire or C or SAW techniques, hybrid techniques, complex antegrade techniques, star technique, mini star technique, and contrast guided star. And the last one, you need to know these ones. And complex retrograde techniques, something like reverse star technique, knuckle guide wire technique, and kissing wire techniques. After the post-procedure, close follow-up in ICU unit is important, and also full monitorization is important for the patients. And the next day, renal functions and hemogram you need to see. CTO procedures is really complex procedures, and it's so popular in these days. So there are lots of publications about this topic. So we need to update ourselves. Also, the technology is improved in day by day. So we need to familiar new equipments about the CTO. So there are new novel guide wires, microcatheters, and they improve maneuverability of the operators. So you need to be familiar about these stuffs. Also, intravascular imaging is really going a high level. So OCT and IVUS guide procedures is getting be better way, a better option for the operators. So also the operators need to be familiar about the intravascular imaging as well. We need to read the new clinical trials about CTO procedures. Now there are some publications about it has some beneficial effects on survival or TLR, but there's so limited knowledge. So now we accept that these procedures for to improve the quality of the life. So we need to know this one. Also, in the future directions, ongoing research and enhanced procedure success and reduced complications is important, and emerging technologies and methodologies in the field of interventional cardiology. Message to take home, we need to know that a CTO procedure that is over without complication, even it's not succeed in recanalizing the occlusion, is a success. And we don't have concrete evidence to support the benefits of survival. Also, we need to choose our CTO candidates carefully and evidence-based, and we shouldn't be overconfident. And if your patient is not in trouble because of the complications, don't forget that every time and next time is possible in CTO lesions. Thanks for inviting me to organization committee, and thanks for everybody. Thanks to everybody.
Yeah.
Any questions?
So attendees, if you have
But when you talk about this particular condition called arrhythmogenic right ventricular cardiomyopathy, recently renamed as arrhythmogenic cardiomyopathy, here the patients, the age of the patients is less than 35 years. So it is pretty much common in young athletes and sportive persons. Now, this is a pretty much unique heart muscle disorder, and which is mainly originating from the right ventricular. And as this disease progresses, the person can die at any time because of sudden cardiac death. And you can see mild physical activity around 13%, exercise 32%, competitive sports 9%, and rest is 23%, whereas sleep is 23%. So you can see that most of the time, those who are involved in excessive exercise are susceptible for this particular kind of problem and subsequent death. Now, the major pathology of this condition is a presence of cardiac fibrosis, this particular thing in the cardiac muscles that will prevent the normal firing of the muscles. So the normal muscle cells are replaced with a fibrosis tissue. And the scarring of this tissue is mainly because death of the cardiomyocytes and subsequent replacement of cardiomyocyte with a type 1 collagen. The type 1 collagen, which is replacing the cardiomyocytes, are not able to do the normal function. And the loss of muscle cells, that is cardiomyocyte, is going to cause problem in the electrical conduction and which disrupts a normal heart rhythm. So because of that, we use the term arrhythmogenic, means arrhythmia is one of the major feature of this cardiomyopathy. Now, so at present, several genes were implicated in the causation of AC, that is arrhythmogenic cardiomyopathy. But traditionally, the first genes to be identified which are responsible for the causation of this disease are desmosomal genes. So any mutations in the desmosomal proteins were responsible for this particular problem. So the first protein to be identified was plakophilin 2, and most of the mutations in the plakophilin 2 are responsible for arrhythmogenic right ventricular cardiomyopathy. And the adjacent cardiomyocytes are attached together with the help of these desmosomes. So these desmosomes are very important because they keep the two cells together so that they could able to electrical and metabolic coupling is possible between them, which is essential for normal firing as well as their normal functioning. But mutations in desmosomes will cause the breakage of this entire interconnected disc or this entire desmosomal structure, and that will cause slowly the disassociation of the muscles and cardiac dysfunctionality. Now, among all the desmosomal proteins, one of the important desmosomal protein is desmoglein, and it is a type 1 transmembrane glycoprotein. The main role of this particular protein is to mediate calcium-dependent cell-to-cell adhesion between cardiomyocytes. This protein has around 4 extracellular matrix, EC1, EC2, these 4 domains, and we have one EA domain, that is extracellular anchor domain, and transmembrane domain, and we have interconnected domain, and we have linker domain, and we have repeat unit domain, 6 repeats of repeat unit domain, and terminal domain. And till now, till 2006, these are the different mutations identified in the desmoglein 2. Now, this particular study, whatever I am talking, it's a reanalysis of transcriptomic data, which is available in the GEO data set. So this particular study was conducted by Chelko SP et al. And they have kept this data in the GEO in Feb 2024. Now, the main purpose of this study by Chelko et al. Was to understand the molecular mechanism behind ARVC, as well as they want to understand the role of NFKB as well as CCR2. These are very important proteins which are essential to activate the immune response. So they have created a double mutant mice with respect to NFKB and CCR2. And here IKB is an inhibitor, like this is the one that will try to get detached from the NFKB, and NFKB will try to migrate to the nucleus. So they made a new form of IKB which will not leave NFKB. So the NFKB is always caught in the cytoplasm and it cannot migrate to the nucleus and transcribe the pro-inflammatory genes. Now, once this particular double mutant strain was created, they went ahead with genotyping and phenotyping of the mice. So flow cytometry around 12 to 16 weeks to see what kind of cells are there. Echocardiography and ECG for 8 to 16 weeks. Histology, immunohistochemistry, RNA scope, in situ hybridization around 16 weeks. And they have measured the different things, measuring the ventricular fibrosis, assessing the cardiomyocyte death, analyzing cytokines level. They performed SN, RNA-seq and site-seq. After that, they looked for the in vivo drug treatment because one of the main reasons was to understand the molecular mechanism behind this particular problem and try to look for a proper drug that would be able to solve the issue. And They monitor the cardiac function around 16 to 24 weeks. And for this entire data, they use Mann-Whitney, or one-way ANOVA and Turkey post-hoc analysis. And they use graph patrism for their analysis. And I have reanalyzed the same data with GE Explorer, and then I have continued with the string database analysis. So this is a density plot during my experiment, during my experimental analysis, and these are the results of box and whisker plot. And this is the analysis. This is the results of the PCA analysis of my analysis, and this is a mean variance plot during my analysis. And this shows the entire heat map plot of this entire experimental set. Now, after all these things, when I got the set of genes from the GE Explorer, I could able to find that one of the gene which was highly downregulated was cartilage oligomeric matrix protein precursor. This protein is a very important part of extracellular matrix, and they are essential to provide stability to the extracellular matrix. Now, this cartilage oligomeric matrix protein is a large pentameric protein, and the main role of this protein is to make, like, interact extracellular matrix proteins. So they mediate cell to matrix as well as matrix to matrix interaction. Apart from that, the interaction of cardiomyocytes with the ECM is pretty much required for a normal cardiac cycle, that is contraction and relaxation cycles of the normal cardiac tissue depends upon their connection with ECM. However, at present, we don't know the complete function of cartilage oligomeric matrix protein. So this protein may be involved in new functions, and that may be also a part of the mechanisms responsible for the causation of ARVC. So as soon as generally what is observed, when the levels or when this particular comp protein is not there in this, like in the heart, so normally we see this condition where downregulation of comp is normally seen during the end stage heart failures. All the end stage heart failures, especially in DCM, you could able to see that there is a decrease in the comp protein. So whenever there is a comp protein is decreased, there is a reduction in the integrin beta-1 expression, reduction in signaling in cardiomyocyte, reduction in the connexin 43 protein levels. Another important point is here there is an increase in MMP9 expression levels. Now, so whenever there is an increase in the MMP9 expression levels, there is a extracellular matrix reorganization, and that in turn is responsible for the dilation of ventricle. Apart from that, your MMP9 activity degrade the ECM, because as soon as there is a low production of COMP protein, there is an increased production of matrix metalloprotease 9, which will degrade extracellular matrix, that in turn reverse the existing condition. And they also recruit monocytes, which are responsible for inflammation, and they also cause smooth muscle cell migration, which is an important part in pathology. So this particular process is involved in so many things, and they're also responsible for during this entire process. And so to understand whether this protein has any connection with the desmosome or not, I have conducted a string analysis, and the string analysis showed me that COMP is interacting indirectly with, through fibronectin, they are interacting with all the components of the desmosome. So there is a just one protein is in between. So there is a direct interaction between your COMP and the entire desmosomal proteins. So loss of COMP or the loss of desmosomal proteins is hampering the other one. So it is like if both are together, even the loss of one will try to remove the other thing. Now, so another point is decrease in the integrin beta-1. So whenever there is a decrease in integrin beta-1, there is a problem with the normal contraction and relaxation cycle of the cardiac tissue, because integrin beta-1 is pretty much important for the stabilization of the normal membrane, and this stabilization leads to the normal functioning of cardiomyocyte. Finally, the last protein is connexin 53. So this particular protein is central to both the electrical coupling as well as mechanical coupling, electrical as well as metabolic coupling of the cardiomyocytes. So this is one of the major connection proteins in the cardiac ventricles, and we have the information on experimental and clinical evidence that indicates that low levels of CX43 alter the conduction and cause arrhythmia as well as sudden cardiac death in the patients who are having reduced levels of connexin 43. Finally, so the loss of ECM, as we discussed earlier, the loss COMP is very important part of the extracellular matrix, and loss of COMP also leads to the loss of connection with the cardiomyocyte to the extracellular matrix. So as soon as there is a loss of COMP, the connection between cardiomyocyte and extracellular matrix is lost. That in turn triggers intrinsic as well as extrinsic apoptotic pathway that is going to cause death of cardiomyocytes, and which was reported, and this is one of the most common feature observed in ARVC. And the cardiomyocytes which are dead are replaced by the fibroblast cells or collagen type 1 fibers. So what is happening? So there are two parts. One is loss of connection with the extracellular matrix is causing them susceptible to the apoptosis. Apart from that, loss of desmoglein 2 is going to cause this particular loss is going to cause changes in the extracellular matrix, and there is a interaction between the different molecules such as your integrin alpha, integrin beta, which are pretty much required to inactivate the TGF beta signaling. So normally in the extracellular matrix, we have the ligands which will activate the TGF beta signaling. But normally the normal extracellular matrix will try to use latent associated protein that will try to catch hold of TGF beta signaling and shut it down. But as soon as we have the degradation of extracellular matrix and there is an interaction between integrin G alpha V and integrin B6, they form a dimer and they inactivate lab protein which is holding the TGF beta signaling system. So as soon as this particular protein is lost from the system, TGF beta is triggered into the cardiac myocyte, and that in turn cause the fibrotic replacement in the entire cardiac tissue. Now the cardiomyocytes have died. That is a part number 2, and the pro-fibrotic signaling is triggering the deposition of adipocytes, which are not compatible with the contraction and relaxation functioning of the cardiomyocyte, and the overall efficiency of pumping the blood is reduced. And further, as we move ahead in the disease progression, what we found that apart from adipocytes, there is a deposition of collagen, type 1 collagen, that in turn inhibits the further contraction and relaxation of the cardiac muscles that may ultimately lead to the death of cardiomyocytes. And so whatever things I have talked, so this is the proof for that. Whenever we have a COMP knockout mouse, which was conducted very long back by Kong, W et al. In 2013, the results clearly show that the loss of COMP is directly causing the dilation of the ventricles. So dilation means thinning, stretching of this myocardium that is not compatible with their normal function. So finally, we can say that the downregulated protein in the transcriptomic analysis is directly associated with the dilation of right ventricle, which is one of the most common feature in arrhythmogenic right ventricular cardiomyopathy. So before this study, most of the genes implicated for ARVC belong to cytosolic, nuclear, and cell membrane proteins. This is the first study which is implicating extracellular matrix proteins in the etiology of arrhythmogenic cardiomyopathy. And this cardiac remodeling is going to cause dysfunction of both sides. So when we talk about the dysfunction of cardiac tissue, this is happening from both the side, that is extracellular matrix as well as inside. And these changes in both the sides are finally responsible for arrhythmia, that is cardiac conduction abnormalities. So finally, what I want to say is the altered composition of ECM is also a major factor in arrhythmogenic cardiomyopathy, which is ignored till this point. So the take-home message is the components of ECM are also responsible for AC pathogenesis, as well as if we try to create a mutational analysis of this particular protein, we could able to find these are the susceptible genes for the causation of ARVC. Thank you very much. So I would like to thank organizers for inviting me to this particular talk. That's all from my end.
Attendees, if you have any questions, you can unmute and ask the speaker.
So I'm going to present one case. This is a 63-year-old female, known diabetic, and she presented with the history of pre-syncope and one episode of the syncope. Next slide. When she reached to the ED, this was the ECG, which showed a pause of around 2.2 seconds, followed by tachycardia. Probably it was the atrial tachycardia, but his some ECG also showing atrial fibrillation. So we diagnosed it as a tachybrady syndrome, and as she was symptomatic, we planned her for the temporary pacemaker. Next slide. So we put the we take the patient for the emergency temporary pacemaker insertion. So, but in spite of multiple attempts, we were unable to reach the RV apex. So finally, we positioned the lead proximally in the RV chamber, just beneath the tricuspid wall, and check for the pacing. Though lead position was not very stable, we positioned it there. Next slide. So electrical parameters were we got the threshold of 5 volts, then sensitivity of 2 volt, and for safety margin we kept the output as a 8 volt. Next slide. So this was the ECG. This was the paced ECG. So after that, we shifted patient to the ICU for stabilization. Then we took the echo. Can you next slide? Can you play this with? So in this echo, you can say there was the RRV dilatation was there, and there was the obliteration of the RV apex. So we diagnosed it as a RV EMF, and we planned her for the permanent pacemaker. We also took the CT, cardiac CT. Next slide. In cardiac CT, you can see there were multiple calcifications in the heart. The septum was fully calcified. Calcification was extending up to RVOT. Next slide. So in spite of we took the patient for the permanent pacemaker implantation, but initially pacing was tried to the RV with the RV ventricular right ventricular lead, and the lead we could not screw the lead in the septum. So we thought there was a apical calcification was there. So we thought we'll try the proximal position. So with 3830 left bundle lead, we tried to position it in the higher septum, but in spite of multiple attempts, the electrical parameters were not satisfactory. Next. So you can here you can see there was a with the left bundle lead, we were planning to put in the left bundle area, but we are not able to screw, and whenever we are able to screw, the electrical parameters were not favorable. So next slide. So what next? So here threshold was more than 8 volt at 1 milliseconds, and impedance was 3400 ohms. So this was not at all acceptable. So next. So what next? So for that, we thought next slide. Okay. So we thought we'll put a LV lead. So we cannulate the coronary sinus with the MB2 catheter, and we took the shot. Next one. Play. In this, you can see there was no favorable posterolateral or posterior vein for the LV lead. So what was the next option we should do? So we thought, can you play again? There was a middle cardiac vein was there. So we thought we'll put the lead into the middle cardiac vein. So next slide. So here you can see we have put the lead in the middle cardiac vein. It was bipolar lead. Next. So this was the these were the electrical parameter. Threshold was 0.5 volt at 0.4 milliseconds, and impedance was 640. This was a pretty acceptable result. So we thought we have done, and then we also checked for the next. We also checked for the diaphragmatic pacing. So diaphragmatic pacing was at 2.5 volt. So as we got the threshold of 0.5 volt, we thought we'll accept this, and with the we'll keep threshold less than 2.5, and so that we can prevent the diaphragmatic pacing also. Next. So after the procedure, we again we finished the procedure, and we again checked the electrical parameters. But at that time, it was the diaphragmatic pacing was at 1 volt. So we kept the then we were not having any other option. So what we did was as patient had the 6 sinus syndrome, it was tachycardia syndrome. AV node was not involved till now, so we increased the AV delay. We kept AV delay at 350 millivolt, and then we kept at AV delay at 350 millivolt. Next. This was the ECG post pacing. Next. So the patient was discharged, and he came 4 days after discharge with the history of recurrent diaphragmatic pacing. So now we were left with no other option. Like we have already put the pacemaker, and there was the AV delay was 350 milliseconds. Still intermittently, the diaphragmatic pacing was there. So we changed it to AIR mode to prevent the diaphragmatic pacing. We thought patient was not very, but we told patient that they need to watch for the symptoms of any giddiness or any syncope for the syncope. Next. So this was the patient after 1 year. Patient is on regular follow-up, but still patient is asymptomatic for any signs of CA, and there are no any CHB recorded after that. Patient is A-paced, V-sense in V-sense mode is there, mode is there. Patient is now symptomatically very better. Next. So now the question was, suppose this patient had RV was very much calcified, and there are chances that in future there might be AV node might involve, and there might means a degenerative change, degenerative AV block can occur. In that case, what we can do? So I read about literatures, but I couldn't found any major things. But the only thing which we can do is the epicardial pacing. But sometimes because of calcification, epicardial pacing also may not be very useful, but that is the only option left after this. We have presented this case in heart rhythm case reports also. Next. So thank you so much for giving me the opportunity to present the case. If any question, please ask.
With an incidence of 4.1 for women and 6.4 for men per 1,000 person years, cardiovascular disease is the primary cause of morbidity and mortality for both men and women worldwide. In both industrialized and developing nations, diabetes mellitus is a significant cause of cardiovascular morbidity and mortality. At present, there are 382 million people who are believed to be diabetic, and by the year of 2035, this number is expected to increase to 592 million. In comparison with non-diabetic population, patients with diabetes mellitus have a greater degree of atherosclerosis, a higher incidence of multi-vessel coronary artery disease, frequently silent myocardial ischemia, and infarction with a higher risk of cardiac events. Patients with diabetes have worse prognosis than those who are non-diabetic. And this is seen both in the immediate setup and after a long-term follow-up. In asymptomatic patients, subclinical atherosclerosis has been detected utilizing several non-invasive techniques such as CT tomography, coronary angiography, which is CCTA, and neck vessel Doppler, NVD. In NVD, a carotid intermal thickness has been measured, and a higher carotid intermal media thickness has a prognostic role in detecting the prevalence of CAD. On CT angiography, the factors such as plaque thickness, calcification levels, stenosis degree, and remodeling features are assessed. The aim of the study was to assess the role of neck vessel Doppler in correlation with CT coronary angiography in assessing CAD burden in diabetic women and men. Our study was conducted on 30 female and 30 male patients aged between 40 to 60 years who were referred for CT coronary angiography for suspected coronary artery disease to a hospital. The study was an observational study and a prospective type. All of the subjects underwent neck vessel Doppler and CT coronary angiography on the same day. A monthly average of 10 subjects that were matched with the inclusion and exclusion criteria over a duration of 6 months were included in the study, leading to a total of 60 participants. The inclusion criteria included type 2 diabetic mellitus patients who were diagnosed for more than a year, aged between 40 to 60 years, and with no history of prior coronary artery disease. The exclusion criteria included pregnant women, patients with atrial fibrillation, and patients outside the age range. All of the participants had given a written informed consent prior to enrollment. And basic baseline demographic data was collected from all the patients, which included patients' sex, age, duration of diabetes mellitus, and hypertension history. All the patients who were referred to our department were evaluated using a 128 slice MDCT, which was of the brand Sumatome by Siemens, with scanning parameters of 120 kilovolts per tube energy with a current of 560 milliampere with 1 millimeter slice thickness and a gantry rotation of 200 milliseconds. Images were obtained while breath holding. The field of view was set from the carina to both domes of the diaphragm. Necessary patient preparation like serum creatinine levels were checked whether if they were in normal limits. A controlled heart rate of 65 beats per minute was maintained, and other routine CT coronary angiography parameters were set. While the CT scanning was being performed, the patients were asked to remain still. The image was acquired on breath holding for 10 to 25 seconds. A non-enhanced retrospective electrocardiogram gated calcium scoring was performed. If the calcium scoring values were greater than 400, the patient was not a candidate for CT coronary angiography, and he or she was advised for a conventional angiogram for articulate evaluation. The start of the reconstruction window for a single segment of the cardiac cycle was determined using the relative approach. The dataset underwent image reconstruction at 2 time periods of 30% of RR and 60% of RR interval. An area of at least 3 faceted voxels in the axial plane along the coronary arteries and an attenuation or threshold of 130 HU or higher was defined as coronary artery calcium. Calcium scores were expressed for each test were calculated by the software and expressed as Agatston score of the CT reference calcium scores. Each high-density lesion in the epicardial coronary artery was recorded, and the sum of all the identified lesions gave a coronary artery calcium score for the entire coronary system as reported by Agatston et al. The Agatston calcium score was calculated by an experienced single investigator blinded to clinical data to quantify the extent of coronary calcium. It was classified as 0 Agatston score was no risk, 1 to 99 was mild risk, 100 to 400 was moderate risk, and greater than 400 was significant risk. This is an image representing the calcium score of 714 in image A, which was significantly increased risk, and a moderate calcium score of 229 in image B, showing moderate risk. Coming to neck vessel Doppler. Neck vessel Doppler was done using the machine of ESOTE MyLab 9XP, where a high resolution linear array transducer was used, and intima media thickness was defined as the distance between the edge of the lumen intima interface and the edge of the media adventitia interface. On a longitudinal display, a near and far vessels were recognized as 2 bright lines separated by hypoechogenic space. The patient was made to lie in supine position with head slightly extended in opposite direction of the carotid artery. The coronary intima media thickness was measured at the far wall of the distal common carotid artery, approximately 1 centimeter to the carotid bulb. The entire carotid system was surveyed bilaterally for the presence of plaques. The thickness of the carotid plaque was defined as a focal increase in thickness of more than 50% of rest of the vessel's coronary intima media thickness. Ultrasound measurements were made by an experienced doctor who was blinded to the results of coronary artery calcium scores. These are image representations showing the coronary carotid intimal media thickness measured in a diabetic male in image A, which came up to be 0.07 centimeter or 0.7 mm. Similarly, in a diabetic female, the coronary artery, the carotid intimal media thickness was 0.6 mm. These are images showing a calcified plaque, a non-calcified plaque, in image A and B respectively. Coming to the statistical analysis was performed using Microsoft Excel. All the categorical variables were expressed as percentages and continuous variables as means. Carotid intimal medial thickness was considered as the largest of the two separate values, either of right and left carotid arteries. The analysis was examined with factors associated with a calcium score of greater than 0. In addition to the conventional risk factors for predicting coronary artery calcification, whether there are additional benefits of the intima medial thickness and carotid plaque were evaluated and investigated. Only two major risk factors were included to limit the number of variables in the analysis, indicating the association bias in univariate analysis with P of less than 0.2. A final series of analysis explored the results on a more detailed scale. Instead of simply the presence of or absence of coronary artery calcification, the coronary calcium score was considered into 4 categories: 0, 1 to 99, 100 to 400, and greater than 400. Each risk factor was considered individually to examine the result of association between cardiac risk factors and the revised result. A p-value of less than 0.05 was used to indicate statistical significance. Data was further compared between male and female diabetic participants. Coming to the results, the mean age at assessment was 52.6 years in the diabetic male group and 53.7 years in the diabetic female group. About 63% of the population was also hypertensive in the male group, and 77% of the study population was also hypertensive in the female group. Both mean duration of diabetes, presence of hypertension, and duration of hypertension were found slightly to be higher in the diabetic female group compared to the diabetic male group. The mean carotid intima medial thickness was 1.01 mm in the diabetic male group and 1.02 mm in the diabetic female group, with no much significant difference between the two. (22) patients, which constituted 73.3% in the diabetic male group, had a calcium score greater than 0, of which 4 had severe coronary artery calcification, 7 had moderate coronary artery calcification, 11 had mild coronary artery calcification, and 8 out of 30 had no coronary artery calcification. Coming to the female diabetic group, 20 patients out of 30 had a coronary artery calcification of greater than 0, out of which 2 had severe, 7 had moderate, 11 had mild, and 10 had no coronary artery calcification. The number of subjects with severe coronary calcification was found to be higher in the diabetic male group. The overall number of subjects with a calcium score of greater than 0 was more in the diabetic male group compared to the female group. Individual association between each risk factor and coronary artery calcium score of greater than 0 was initially examined in a series of univariable analysis. The mean carotid intimal medial thickness and carotid plaque were significantly associated with the coronary artery calcium score, with p-values of 0.046 and p-value of 0.26 respectively in the diabetic male group, and the p-value of 0.008 and p-value of 0.011 respectively in the diabetic female group. The significance was more profound in the diabetic female group when compared to the diabetic male group. The presence of hypertension also showed a significant positive association in the diabetic female group when compared to the diabetic male group. where a significant association could not be established in the male group. No other significant association could be derived from our data set in terms of age, sex, and duration of diabetics. Of the 22 subjects in the diabetic male group with a calcium score of greater than 0, 14 had a concomitant carotid plaque, and all 4 patients with severe calcification and all 7 patients with moderate calcification were associated with the presence of carotid plaque. Only 3 patients out of 11 with mild calcification showed the presence of concomitant plaque, and 8 patients with a calcium score of less than 0 showed no carotid plaque. Of the 20 subjects in the diabetic female group with a calcium score of greater than 0, 14 had a concomitant carotid plaque. Both patients with severe calcification and all 7 patients with moderate calcification were associated with the prevalence of carotid plaque. 5 out of 11 with mild calcification showed the presence of concomitant carotid plaque, and 10 with a calcium score of less than 0 showed no plaque. On further correlation with the carotid plaque and categorical division of coronary calcium scores, a calcium score of less than 0 showed a strong negative correlation, reinstating that patients with a carotid plaque were associated with coronary artery calcium score of greater than 0, but not with a score of less than 0 in both diabetic male and female group with p-values of 0.026 and 0.011 respectively. A positive correlation was established with the coronary artery calcium score of 100 to 400 Augustins units and carotid plaque with a p-value of 0.02 in both groups. No other significant correlation could be derived from the categorical data. The significance was more profound in the female group. Similarly, on probing the further correlations with the raised carotid intimal medial thickness with the calcium scores, it was found that a strong negative correlation was established within a calcium score less than 0 with the raised intimal medial thickness. This validated that the above derived correlation of patients with carotid intimal thickness and calcium score greater than 0, but not calcium score less than 0. No other significant associated could be derived from the categorical data set. However, 100 to 400 Augustins group was close to establish an association with p-value of just 0.05 in diabetic male group. This is a representation in a graphical manner. These are graphs, tabular columns showing p-value with significant values with intimal medial thickness. And this is a key summary of all our findings. Coming to discussion. Our study found that the coronary artery calcifications are common in type 2 diabetic mellitus patients, and our analysis further revealed a strong positive correlation of coronary calcification with carotid plaque and carotid intimal medial thickness. How our study stands in comparison to other studies is it was showing concordance with majority of the recent studies, except one study conducted by Dilation in 1997, which showed divergent findings. The key takeaways include: most studies align with our findings that carotid intimal medial thickness and carotid plaque are valuable predictors of coronary artery disease, particularly in diabetic populations. Our study strongly validates the role of carotid plaque as a marker of coronary artery disease in line with the Rotterdam and Cohen studies. Unique findings are, unlike the Dilation study, our study demonstrates a robust predictive role of the intima medial thickness in carotid artery disease, especially for diabetic women. Our findings emphasize the gender-specific associations in diabetic populations, a dimension which is less explored in the other studies. Limitations of our study include: as this was a study population was relatively small and observational, the validity of any of these conclusions offered need to be tested in a larger population before any revision of guidelines can be recommended. The study was conducted on patients who were referred for CT coronary angiography for suspected coronary artery disease, creating a referral bias and a higher number of subjects with suspected coronary artery disease. Whether the results of the study can stand true for asymptomatic patients needs to be evaluated. The role of drugs such as antihypertensives, vasodilators, hypoglycemic drugs, and insulin were not considered for the study. Other confounding factors such as smoking, hyperlipidemia, obesity, which are high risk factors, are not analyzed in our study. The study was conducted in subjects aged between 40 to 60 years. However, in view of the rising trend of young MI and premature atherosclerosis, similar study can be conducted in younger populations to assess the disease burden in coronary artery disease. To conclude, our study supports that non-invasive investigations such as neck vessel Doppler can be used as a screening modality for assessing coronary artery disease burden in high-risk diabetic women and men. Neck vessel Doppler giving various surrogate parameters such as carotid intermedial thickness and carotid plaque in correlation with calcium score by CT coronary angiography can play a significant role in assessing the coronary artery disease burden in men and women with diabetes and hypertension, thereby helping the clinician to assess the future risk for stroke or myocardial ischemic events and to plan active interventions. These are my references. Thank you.
If any of the attendees have any questions, you can unmute and ask the speaker.
In Thailand, Bangkok. And so this is a case presentation. The SCADL, the new medical frontier, is a case report. And so this is the overview of the whole presentation. And so this is a case of 36-year-old female presented with ischemic chest pain, suggestive of myocardial infarction, to a peripheral hospital last year, 2023. So initial symptoms were just chest pain, suggestive of MI, and with a past medical history of multiple TIAs and migraines. Also, she had family history of strokes, and father and the grandfather both. And general and cardiovascular examinations were normal. And initial investigations, ECG showed anterior STEMI, troponin was high, and echocardiography showed wall motion abnormalities suggestive of anterolateral wall ischemia, with a mild LV impairment with an ejection fraction of 45%. So I think they have done an initial evaluation of young MI because she's young, below 40, and a stroke. And so all the basic initial conventional investigations were normal. And so as far as the management of STEMI, so they have thrombolyzed her with tenecteplase. So they didn't have, it's a peripheral hospital to reach for primary PCI. And then after that, she was transferred to our unit, that is tertiary care center in Colombo, Sri Lanka, with cath lab facilities for angiogram. And so this is the angiogram is date. Now you can see very well here. And so there is no occlusive disease. And what you could see is a linear translucent shadow, very linear, proximal LAD. And flow is normal. And so that was actually a spiral dissection of LAD with TIMI3 antegrade flow. And so we initially made a diagnosis SCAD, type 1 SCAD, because a linear shadow, and spontaneous coronary artery dissection. So we went ahead with IVUS just to diagnose it. We were thinking whether it's a thrombus, linear streaks like thrombus. And so, but anyway, so what we show is a typical dissection. And so with an intramural hematoma, and there's a dissection flap and compromising little, I think, the lumen of the LAD. And so this is the initial findings. And also they had the brain scan, that those, the pictures you can see, now if you see very carefully, there are periventricular hyperintensities with small lacunar infarcts suggestive of leukoencephalopathy. So these are hyperintensities, small area of hyperintensities, red arrow shows. And also you see the lacunar infarct, translucent areas all everywhere. And so they are actually reported as lacunar infarcts. You can see one here and one there. And so it's a leukoencephalopathy picture. So this is a case of actually a spiral dissection of LAD and a leukoencephalopathy picture. And so subsequent management, patient was long-term single antiplatelet and statin therapy was initially started by the neurology team because he presented with strokes. And so we diagnosed SCAD, spontaneous coronary artery dissection, managed conservatively. We didn't do anything after that. And so accordance with the guidelines. And we continued aspirin and statin therapy because she had initial high LDL level, but by the time we check it, it was actually 107 LDL levels. So we put her on beta blockers and angiotensin AC inhibitors because LV function was little impaired initially. And so nothing else. So we diagnosed CADASIL actually. Now see, the CADASIL is a syndrome already described, cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. So this patient had this. And so on the brain MRI, the scan. And so also they have, and she's a female, less than 50 years of age, history of migraine, history of recurrent TIA, brain MRI scan with all these suggestive features, and strong family history. So if you have this kind of picture, of course, it's a CADASIL. But the thing is here, so CADASIL also could give rise to the coronary artery dissection, but it's extremely rare. And she presented with the CADASIL picture with the coronary artery dissection. We were a little puzzled. So that's why we went ahead with genetic analysis, either to diagnose CADASIL or we thought of thinking of something else. So what we found, what we thought, and apparently what we saw is different mutation. CADASIL, you should have NOTCH3 mutation in CADASIL. It was not seen. So they were looking for other mutations. So this finally we found THSD1, that is thrombospondin type 1 domain containing protein 1 genes mutation. So that is a totally different mutation and to compare to CADASIL mutation. And so genetic analysis, you can see is TSSD in details. So they are the cytosine nucleotide is replaced by guanidine, the nucleotide. Ultimately, what happened is arginine, which was supposed to code by the cytosine, and then replaced by glycine. So it's a point mutation. So this is NOTCH3 and TSSD in details. And so both cytobands, and then you can see that point mutation. NOTCH3 is actually chromosome 19, but TSSD is chromosome 30. Two different chromosomes. It's two different entities. And so here is a SCAD, actually, is genetic test is done. Finally, we found NOTCH3 negative, TSSD positive. So we label it as CADL. It's because spontaneous coronary artery dissection with leukoencephalopathy. And so in this kind of mutation, what you see is extracellular myeloprotein dysfunction. In case of CADASIL, you see as a smooth muscle dysfunction in intima, in small vessels, medium caliber and small caliber blood vessels. And here is totally different one. This causing extracellular myeloprotein dysfunction causing cerebral arteriopathy, coronary arteriopathy. And so if it is cerebral arteriopathy, periventricular leukoencephalopathy like picture, and causes strokes and TIA, this patient has. And coronary arteriopathy, of course, they can come with dissection. And in this patient, so ultimately combined, we diagnose, label it as SCADL. And it has never been described before. So we thought we should describe and label it as SCADL. So follow-up and further assessment, you can see repeat echocardiography, ejection fraction was 55, improved, and mild apical hypokinesis. Repeat coronary angiogram, you can see it after 6 months, and healing dissection. You can see it's little bit. The linear shadow, translucent shadow is very linear. It was proximally before, now it's in the mid vessel is very small. And we didn't want to do the IVUS at this stage because IVUS is, you know, that IVUS is contraindicated in dissection, coronary dissection, even though we did it initially. And so then follow-up CT images, always you have to follow up these patients. CT images, you can see coronary artery LAD is very normal. And so you can see here, so no dissection at all. So she is back to normal. I saw her 2 weeks ago. She's doing very well. And so in conclusion, this case provides an eye-opener to a rare clinical scenario suggesting a new syndrome linked to TSSD mutation is called SCADL. And continuous research is essential in this case because we have to diagnose more and more cases and to fully understand the range of TSD mutations and their clinical implications. It is crucial to consider genetic testing if a patient presents with SCAD. So I suggest everyone, if somebody is coming with SCAD, and please do the genetic testing, see whether it's a SCADL or CADASIL. And so especially if the patient is giving a history of neurological features of TI or stroke. Furthermore, this case underscores the necessity of targeted therapies tailored to specific genetic mutation, and the essential the role in genetic counseling also very important. We have to check and go and check other brothers and sisters. We have done it, and they are all negative in these patients. And so this was reported in the ESC last year in August, and then so as a case report, and you can read it in the details. And thank you.
Attendees, if you have any questions, you can unmute and ask the speaker.
The presentation is patient experience in TAVI procedure, TAVI nurse program. TAVI, transcatheter aortic valve implant, has become the treatment of choice for patients with severe aortic stenosis of high surgical risk, and also a valid alternative to surgery for patients with intermediate and low surgical risk. The expansion of TAVI indication, the fact that procedures has become minimally invasive, together with the aging of population, suggests that the number of implants is going to increase dramatically over the next year, as shown in the graph. This is leading to development of evidence-based TAVI patient-centered programs that require a multidisciplinary and individualized team. Incorporating the nurse into this program is becoming vital to development of the TAVI nurse role. Given the evolution that the TAVI implementation were undergoing, nurses of the United Kingdom and Canada decided to develop a specific role to attend and care for the TAVI patient. They gave us a great gift, the publication of an article in 2014 explaining what a TAVI program may look like and a guide about how to develop a TAVI nurse role, and we had to take advantage of this momentum. They specify what the competencies of this nurse should be: knowledge of cardiovascular and structural pathology, valvular heart disease, geriatric care and possible comorbidities, ability to anticipate decision and care, efficient patient management skills, and ability to manage patient motivation and expectations. The responsibilities will also be triage and coordination, point of contact for patient and family during the whole process, participates in clinical triage, in the management of the waiting list and coordinates the follow-up. Clinical assessment, review the patient clinical history, coordinates the performance of pre-procedural diagnosis tests, and makes a comprehensive assessment of the patient. Patient and family education. The nurse oversees the education, assesses managerial expectation of the patient, and develops an early discharge plan. And finally, leadership as a characteristic of nursing. The nurse has the ability to work in team, participates in the HER team or TAVI team, collaborates in development of standardized protocols, in case selection meeting, and in outreach initiatives like this. But what does a TAVI nurse do? The TAVI program is integrated by the HER team, a multidisciplinary team, and the nurse is part of it. The program starts with a patient who is diagnosed with aortic stenosis by their GP or cardiologist and is referred to the HER team. If the patient is not candidate for surgery, the patient are referred to the TAVI program. An exhaustive clinical, functional, and cognitive evaluation is carried out, in which the nurse will play a crucial role through her nursing consultation. Preliminary clinical assessment tests such as echocardiogram, CAT scan, or coronary angiography are performed, and the nurse is in charge of organizing appointments. A functional cognitive assessment is carried out, in which the nurse plays a leading role with the scales of dependence, quality of life, fragility, socio-familiar support, and cognitive deterioration. The nurse ensures that the results of these tests are included in the clinical history and review comorbidities, allergies, medication, education for the patient and the family, and identify factors that may promote or impede the success of the TAVI procedure. All this information is sent back to the HER team and is analyzed to assess whether the patient is candidate for TAVI, for valvuloplasty, or to palliative care. The waiting list is organized and make an individualized report for each patient. Without losing sight of the concept of utility, because the TAVI is not an option for everyone. So in that case, the TAVI nurse have a key role of accompanying the patient and the family in the referral to the palliative care. If the patient is candidate for TAVI, the TAVI nurse meets with the patient and the family the week before and gives the education, already specific for TAVI, with a much more detailed description of the whole admission so the patient arrives in the best conditions, and also prepares the discharge plan. The peri-procedural care of the TAVI nurse is to visit the patient during the admission in the daycare unit, in the cath lab, in the cardiovascular ICU, the cardiology ward, to see how the patient is doing and how he is progressing. The TAVI nurse prepares the patient for going back home, assesses whether family support is required, technical eyes, remind appointments and medication, sign of alerts, maintaining continuous education and support for the patient. The TAVI nurse participates also during the follow-up. There is a nurse consultation between the first week and the first month post-TAVI, depending on whether the patient is discharged early according to the protocol of each hospital. The cardiologist sees the patient at 3 months, and the patient is seen again by the nurse between 6 months and a year after TAVI. What is our experience in the University Hospital of Salamanca, Spain? We wanted to improve the TAVI process in our hospital and as well to implement the TAVI nurse role. In our hospital, Salamanca, we started with a bibliographic research of everything published on TAVI nurse, and with the contact with pioneering nurses as Gemma McCalmon and Sandra Lauk. And we were clear about one thing. We wanted our TAVI program based on pillars such as the patient being the center of the process. Quality of life, not only understood as effectiveness and efficiency of TAVI procedure, but also from the point of view of quality of life as perceived by the patient, the PROMs. With a model based on shared decision-making to have an informed and empowered patient. Considering their preference, motivation, expectation, and above all, their experience, the PREMs, for empowering the patient in this TAVI patient journey. We set out to improve our efficiency, the time from referral to treatment, reduce hospital stay, improve follow-up, provide a better educated patient, and improve patient satisfaction in the whole TAVI process. This, together with the nurses' interest in implementing the TAVI nurse role, led to our project. We created a multidisciplinary group that included the whole health area, hemodynamics, critical care, and clinical. And this expertise together was our key to success. We built a value stream map to identify areas for improvement. And we decide that we will implement the TAVI role with a pre-consultation and post-TAVI consultation for patient follow-up, and also a fast-track protocol for TAVI. To measure the performance of all these change, we consider to follow the measurement of some indicators along the process, operational, PROMs, and PREMs, knowing that the impact will not only be due to the implementation of the TAVI role, but to all the change in the program. This was very important in our design. We developed the content of the nurse consultation for pre and post procedure. We developed an education session with simple slide 12 in the pre-TAVI clinic, definition or symptoms of aortic stenosis, explanation and a video of the technique, vascular approaches, type of valves, or analgesia. We discussed also about the possible complication of the procedure and perform a virtual tour throughout the different units where the patient will be admitted. Because we were concerned that patients and families forget much of the information that we provide them, we also developed a brochure on paper as a reminder, so they can read it carefully at home. This brochure includes the basics: location for admission, patient arrived the same day of the implant, nil by mouth, indication about medication to take or not to take, come with his family, and a map our hospital. We make a comprehensive assessment of the patient using different scales: CAT dependency scale, SF36, and Eurocool 5D quality of life scale, socio-familial assessment with the Gillian scale, cognitive assessment with scale mini mental state examination, MSE, frailty assessment with frail and EFT scale. And we also use our own creation scales: early detection of cardiac amyloidosis in patients with aortic stenosis, a scale of the importance given by the patient and the family to be informed and participate in their care, and another scale on the patient expectation of TAVI to be assessed during the follow-up. For the follow-up, we made another self-developed scale to evaluate the experience and satisfaction during the whole TAVI process to help up to improve. We implemented the early discharge protocol for TAVI, where the TAVI nurse used in the TAVI clinic oversees the preselection of candidates with a specific checklist. The benefits of implementing the TAVI nurse are many and based on existing evidence. For the patient, it improves expectation, knowledge, and our overall patient satisfaction, reduce patient anxiety by having the TAVI nurse as a point of contact throughout the process. In our experience, we have seen that the family and the patient are grateful and more involved. For the team, improves communication, optimizes resources, and support decision-making. We have a weekly meeting for waiting list management, scheduling and review reports, and patient with the cardiologist. And for the process, prevent complication and readmission, provides continuity and quality of care, facilitates early discharge, and allows for better patient follow-up. I would like to share with you our own national paper on the TAVI nurse. We created a national working group of nurses on TAVI nurse with practical details that help to implement the TAVI nurse role. We review all the available and most up-to-date scientific evidence and taking advantage of experience of other leading centers in this role and using the momentum that they initiated to implement TAVI nurse in our country, Spain. To summarize, the TAVI nurse have the competencies, experience, and leadership to lead a specific TAVI nurse program. It enables our patient to become an informed and better prepared, and for them to feel that they are part of the process. But we did one more step. We saw that the growing evidence of better clinical outcomes, higher post-TAVI survival, the expansion of TAVI indication together with the aging of population have triggered a dramatic increase of TAVI implant, both worldwide and in our country as well, Spain. Nonetheless, few studies have approached this procedure from the patient perspective, exploring the impact of TAVI on the patient and or their own experience. For that, we designed a new questionnaire that measures the expectation, perceived quality of life, and experience of TAVI undergoing TAVI, and to evaluate the results using this questionnaire. For this purpose, a cross-sectional descriptive study was designed and carried out with patients included in our TAVI nurse program between August 2023 and January 2024. This program, led by nursing, provides assessment in pre-TAVI consultation, support during the hospitalization process, and during the follow-up once the patient is discharged. At this last step of follow-up, we use our questionnaire with the patient. A specific questionnaire was designed to evaluate the patient experience during the whole TAVI process, from diagnosis to discharge, including follow-up, in collaboration with a multidisciplinary group, but the most important thing, in co-creation with the patient. The patient collaborated in developing the questions, incorporating and deleting questions or words to facilitate its understanding. To establish the theoretical framework, a bibliographic review was carried out. The questions were selected for their relevant, trends, and pertinent. The question used a simple and clear language, and at each stage, items that could cause semantic and comprehension difficulties were identified. The timeline started on January 2023 with a literature review focused on patient experience on TAVI and TAVI patient. Then we selected all questions of review to analyze and eliminate the repeated ones. We elaborated a first draft with 90 questions, the second draft with 50 questions, the third draft with 44 questions, and the last review, performed by a panel of experts that include patients, led to a final questionnaire. The questionnaire is based in PREMS, acronym for Patient-Reported Experience Measures, and PROMS, Patient-Reported Outcomes Measures, specific of TAVI process. The questionnaire consists of 29 items divided into 3 blocks: pre-procedural, intra-procedural, and post-procedural that include follow-up, and they are evaluated with a Likert scale from 1 to 5. Some of the questions in the pre-procedure phase ask the patient if he or she considers that they have taken part along the decision-making process, if they are satisfied with the time on waiting list, they provide pre-procedure information, their relationship with the TAVI nurse, and overall patient satisfaction. Intraprocedural items encompass wait time, accessibility, satisfaction, information, staff interaction, and state of the facilities. And in the post-TAVI phase, the patient is questioned if the process met his expectation, hospitalization time, improvement of symptoms, and doubt resolution. 100 patients undergoing TAVI participate by answering the questionnaire 1 month after the procedure during the TAVI nurse follow-up clinic. The results, 55% were female, average 81 years old. 92% were satisfied with information from the nurse before TAVI procedure. 96% were satisfied with information from the nurse during the whole admission. 98% were satisfied with the time that had been dedicated by the nurse throughout the process. 95% were satisfied with the nursing kindness and their professional skills. 89% believe it was worth undergoing TAVI. 83% consider post-TAVI symptoms have improved. For 76% of the patients, the process met their expectations. 87% consider the information provided by the nurse during pre-procedure consultation helped them to organize and know the process. 87% state that they knew who is the contact if they had questions during the follow-up. And finally, 88% stated that the nurse was important for them to be calm, well-informed, and prepared to face a TAVI procedure. Regarding the recommendation of TAVI to other patients and the patient satisfaction throughout the whole TAVI process, it was rated excellent according to the Net Promoter Score Patient Experience Index. In conclusion, this study focuses on the importance of integrating the patient into the decision-making, setting realistic expectations, and getting informed patient. Nurse leadership plays a key role in patient preparation, giving patients a greater control over their illness and helping them to increase overall patient satisfaction. To summarize, evaluating the patient experience not only allows for continuous improvement, but also impact on health outcomes by identifying areas for improvement in quality of care, contributing to the sustainability of the health system. Active inclusion of the patient through the co-creation with the patient in the design of the questionnaire is essential to put the patient at the center, incorporating their perspective and voice in the TAVI process and empowering the patient. Thank you very much.
Attendees, if you have any questions, you can unmute and ask the speaker. Could you please enter your mail ID in the chat box?
To introduce myself, by education, I am applied mathematician, so I am not a medical doctor. So being here in this wonderful group of specialists and presenters, I'm feeling a little bit unorthodox. Nonetheless, during the last decade, we had quite a strong cooperation with the Institute of Cardiology in the Medical University here in Kaunas and the Institute of Heart Mathematics in US. So the topic, the presentation today is entitled, as already announced, the relationships between ECG cardiac intervals, theory and applications. So once again, thank you very much for being able to give this presentation here. I will start with the outline. So I will introduce cardiac intervals and algebraic relationships between them, how we are using in our research. Then I will discuss the collapse of complexity during the stress test. Then introduce the detection of anaerobic threshold based on RRQR algebraic relationships. Then I will discuss the detection of ischemic episodes based on JT-ST algebraic relationships. Then the visualization of electrical auricle vagus nerve stimulation based on RR-JT-QRS algebraic relationships, then detecting of atrial fibrillation episodes based on 3D algebraic relationships between cardiac intervals, then the arterial blood pressure regulation during the stress test, and finally the concluding remarks. So if we start on the cardiac intervals, why we are interested in digging into those intervals and algebraic relationships, why this is necessary? Well, the short answer is that the insufficient identification of the specificity of relationships between ECG parameters forces us to look deeper into the ECG dynamics. Also, the fixed model of relationships between ECG parameters cannot always hold even for a single particular person. And time average relationships between ECG parameters are usually not able to represent the complexity of these relationships in different time scale lengths. So I will start from a formal definition of perfect matrices of Lagrange differences. This is a little bit mathematical, but I'm not going too deep. Just in introducing a second-order square matrix where elements of that matrix do satisfy the following requirements. There are 5 actual requirements. For instance, all elements of the matrix must be different. Zeroth order differences are located on the main diagonal, and first order differences are located on the secondary diagonal. And indexes X and Y can take only one of the three possible values, where delta is the time lag, the time delay, and n is the current moment of the time. And finally, the perfect matrix of Lagrange differences is lexicographically balanced. The number of symbols of x and y's in the expression of all elements of the matrix is equal. So if we have two time sequences, two time series, x and y, so there are 6 elements we are trying to map into the structure of the perfect matrix of Lagrange differences. And we give 3 examples which are non-perfect matrices. For instance, the null element is non-allowed, or lexicographical balancing is missing, or the time balance is violated. And the last example in the bottom line is an example of a perfect matrix of Lagrange differences, which complies to all the necessary requirements as defined in the previous slide. So it appears that we have 18 different matrix architectures where all those requirements are satisfied. And this example, as shown in before, it stands for the matrix architecture number 1. And what we are trying to do, we use 2 sequences of synchronously measured cardiac intervals. As already mentioned, time series X and time series Y. We map those 2 time series into a sequence of perfect matrices of Lagrange differences, and finally map to a sequence of algebraic parameters. So this was a short introduction on the mathematical aspects of data analysis. And now I would like to move to the definition of the collapse of complexity occurring during the stress test. So this is a standard bicycle stress test, as shown. The 12-lead ECG analysis is performed for the person spinning the bicycle, and the load is sequentially increased until the person is not able to continue the exercise. And the horizontal axis in this figure shows the number of the RR interval, so the number of the contraction. And the vertical axis shows the mapped algebraic relationships between RR and JT intervals. The red wavy line shows the evolution of the algebraic parameter during the stress test. And we see that at the end of the load, this algebraic parameter, it almost collapses to 0. And then during the recovery stage, it's necessary to mention that ECG is recorded also 5 minutes after the termination of the load. We observe that the algebraic parameter returns back to this initial status, which was before the starting of the stress test. If we map the algebraic relationships into the phase plane, we may observe how the stability of the attractors is lost when the load is sequentially increased, and every step of the higher load makes the attractor to not only to lose its stability, but also trying to find a new stable location around the new the new situation of the load. Finally, when the person is not able to continue the stress test any longer and the load phase is terminated, we do observe this actual effect of the collapse of the complexity. And then during the recovery phase, we again observe the moments of transient recovery where the transient attractors can be identified and represented in the phase map of the recovery signal. The next area of application of this algebraic mapping is focused on the detection of anaerobic threshold. Now we are again introducing the other two cardiac intervals, RR and QR. And the panel A shows the increasing load until the end of the load phase, and then the following the recovery phase. Again, the load is increased in a stepwise manner, and the horizontal axis stands for the number of the heart contraction. Next, we need to mention that the power of the load is measured in watts, and the panel B shows the ratio between the carbon dioxide and oxygen concentrations in the exhaled air, and C shows panel C shows the systolic and diastolic pressures. Panel D, the variation of the RR interval in milliseconds. Panel E, the relationship between RR and QRS duration intervals. And F, G, and H shows the attractors before the anaerobic threshold, after the anaerobic threshold, and before the termination of the load, and during the recovery process. The vertical dotted line denotes the anaerobic threshold based on the ECG analysis. The thick vertical blue dashed line denotes the anaerobic threshold based on the exhaled air, and the thick vertical black dashed line denotes the termination of the load. It's important to mention that the anaerobic threshold is detected only based on the algebraic relationship between cardiac intervals. So the concentration of O2, CO2 is not requested to be measured in the exhaled air during the stress test. The blood samples don't need to be necessarily taken during the stress test. ECG analysis alone is capable to identify this transient behavior of the mode. And if we look at panel E in particular, we may see that the relationship between those two cardiac intervals shows that the cardiovascular system tries to move to a different mode of the behavior, but this transition happens too fast, and the system still remains and moves into the direction of the collapse of complexity. And only after the second, the third step already shows a clear change in the dynamical behavior of the cardiovascular system. So again, if we look at the data, the algebraic relationship between cardiac intervals serves as a standalone indicator for both the determination of the anaerobic threshold, but also, and it's even more important, for the characterization of the performance of the person during the load and the recovery processes. So, as already mentioned, the thin vertical line shows the ANT detected by RQR intervals, where the blue line detects O2 CO2 period, and end of the load is marked by thick vertical line. So this is truly a standalone indicator for important measure, which shows not only the appearance of the transit, but also the dynamical behavior after the transit and during the recovery. The other application of the algebraic relationships between cardiac intervals is based on the detection of ischemic episodes. And now we are using other intervals, JT and ST. Again, we are using the perfect matrices of Lagrange differences and mapping those sequence of matrices to the algebraic outcomes. So again, we have two panels here. Panel B shows the increasing load during the stress test. Again, we do observe the collapse of the complexity at the end of the load phase. And the left y-axis in part B represents the power of the load in watts. The algebraic JT-ST relationship is represented by the thin dashed black line in part A, and the right y-axis in part B represents the variation of the RR interval in milliseconds. So the thick black solid vertical line in part A marks the end of the load, and two colors, red and blue, mark those dipping episodes before the termination of the load and at the beginning of the recovery. So early detection of the ischemic episodes is based on the ratio between the colored areas, and actually this patient data depicted in this slide shows a person with ischemic episode when the area plotted in blue is completely missing. The previous slide showing those two areas marked in red and blue shows a healthy balance between this self-regulation of the cardiac vascular system before the termination of the load and after the termination of the load. The recovery process is clearly exaggerated, and this dip, the blue dip, is completely missing in panel A for this person. Another application of algebraic relationships between cardiac intervals is applied for the visualization of the effects of electrical auricle vagus nerve stimulation. Now we are employing 3 cardiac intervals instead of 2. In particular, RR, JT, and QRS. The natural sensory innervation of the auricle is depicted in panel A, and the artificial stimulation in panel B, when a set of electrodes is mounted into the surface of the human air, and the electrical stimulator is emitting the electrical signals which stimulate the nerve. This is a short visualization of the baroreceptal control loops in the context of the model of integral evolution. The red blocks, they depict the vagus nerve stimulation, the ECG system, and the 3 cardiac intervals, RR, QRS, and JT. So the cardiac output measured again by a 12 lead cardiac analyzer allows to register those effects. And now a series of experiments are performed with stimulation and with placebo effect when the electrodes are mounted in the air, on the surface of the air, but the electrical signals are not executed. The parts in red show where the electrical stimulation is switched on, the black when it's switched off. Now, if we look at panel C, we see that the stimulation brings the complexity of the system in the phase space and on the top right corner. So the complexity of the response of the cardiac of the self-organization of the cardiac system becomes higher when the stimulation is switched on, and the longer it stays switched on, the longer we move to the top right corner, and then the recovery brings back into the initial stage. When in the placebo situation, we do observe just the random wandering of the system in the phase space without clear observation if the system, the complexity of the system is increasing or not. So this type of research helps the engineers to design the optimal control protocols for the electrical stimulation for a particular patient. Finally, then, continuing the presentation, I would also wish to introduce our research on the detection of atrial fibrillation episodes based on three-dimensional algebraic relationships. So if you, in one of the previous slides, when I was introducing the perfect matrices of Lagrange differences, I mentioned we have 18 different matrices, and the type number 1 was represented by this architecture shown on the left. Now, having the three-dimensional matrix, it appears that we are able to expand the algebraic structure of the matrix. And actually, this is the schematic diagram illustrating the relationship, the algebraic relationship between three time series, X, Y, and Z. What enables us to analyze the relationships between three cardiac intervals instantaneously. So panel A, B, and C, they show the duration of the RR interval, duration of the JT, and the duration of the QRS cardiac intervals. And now if we explore the algebraic relationships between cardiac parameters, JT and QRS, and if we compute the variance of this algebraic signal, in panel A, the variance is 0.0218. Panel B, JTRR, yields 0.0059. And finally, the QRS and RR results into 0.0186. However, it appears that if we combine all three cardiac intervals together in a one three-dimensional matrix, we are able to expand the variance of the algebraic signal. In other words, the sensitivity of the method is increased. So if we consider the variance of a particular patient and plot the variance of the healthy and the unhealthy cohorts, health is shown as the blue Gaussian variation and unhealthy as the red Gaussian variation. And if we use 1 sigma rules to construct the interval of the variation between the means and the standards, so we are able to construct the machine learning approach, which helps to plot the probability of a new incoming candidate, the probability of his risk of being prone to artificial fibrillation episodes. So plotting these variabilities help to construct the semi-automatic gauge tool, which helps to visualize the risks of getting some fibrillation episodes from short records of ECG signals. For instance, for that particular person, and keeping in mind his variance and his data, we now see that the incoming candidate results in a risky zone. So it doesn't mean that this patient needs an instantaneous medical attention, not at all. It's just a warning signal that he may look for the consultation for deeper analysis, for longer term monitoring for the possible identification of fibrillation episodes. Finally, the analysis of the arterial blood pressure regulation during the stress test. Again, it's a quite specific investigation, and additionally to the ECG analysis, we measure the arterial blood pressure, the systolic and diastolic pressures during the exercise and during the recovery. And each individual executing the load will experience an increase in the heart rate and the blood pressure. But the primary goal is to identify a fine balance between the two. And the way how we are trying to incorporate this information, which describes the autoregulation between regulatory, executive, and supply system, is again represented by subtle relationships between RRJT, cardiac intervals, and systolic diastolic blood pressures. So we split the analysis into the load and the recovery phases, plotted in red and blue. And panel B shows the normal ABP, systolic, diastolic. And then we measure and compute the average algebraic relationship between RR and JT for each minute, plotted in small circles, and then separately investigate and reconstruct the slope line and reconstruct the slope coefficient of the slope line approximating the evolution of the condition of the cardiovascular system. Notably, the horizontal axis shows the ratio between systolic minus diastolic times systolic, and the vertical line shows the algebraic relationship between RR and JT. So we may observe that for a person having high arterial blood pressure, we see a clear difference in the slope coefficient during the load. Though looking at the dynamics of the algebraic parameter, or even looking at the raw signals itself, there's no clear difference between the dynamics of the system. But again, if we are able to use the machine learning to automatically classify the incoming candidates and using the Gaussian interpolations from the healthy and the unhealthy cohorts, we are able to construct two interpolations for the load and for the recovery, and we see that the recovery is not statistically significant to being able to reproduce that sort of classification. But for the load test, we may see that we are clearly able to indicate which regulatory channel is used to control the blood pressure during the stress test. Is it the right branch connecting the regulatory system or the supply system, or the left branch, and the thickness of the lines used for the visualization of those regulatory routines depends on this identified probability in the probability plots. And for instance, the unhealthy patient is already marked and warned by the thick left branch connecting the regulatory and the executive system. So this study paves the way for identifying arterial blood pressure dynamics during the physical activity and avoiding cases where a sudden increase in ABP occurs or a person experiences hypertensive reactions and enters into a hypertonic state. The establishment of such an early warning system based on machine learning algorithms can be especially beneficial for those who use antihypertensive medicines to control the blood pressure. Although blood pressure is kept under control, there may come a time when the cardiovascular system cannot handle the load and all self-regulatory systems collapse, causing the blood pressure to rise and lead into an alarming health condition. This study leads to the identification of self-regulatory system control mechanisms in the cardiovascular systems, and thereby could save lives. And I would like to conclude my presentation by giving a few conclusions. First of all, novel algebraic relationships between cardiac intervals provide new possibilities for the insight into the complex dynamics and self-organization of the human cardiovascular system. And those novel insights provide tools for the early diagnosis of different diseases and may even help saving lives. So this concludes the presentation, and I would like to thank everyone for the attention. If there would be any questions, I would be happy to try and giving any answers.
Sorry, Dr. Anna couldn't join the webinar today.